So, hello everybody. We welcome you to the webinar about SCIROCCO, a tool to evaluate the degree of maturation of the integrated care that's provided. It is a webinar modus, so you can just see the different speakers on top, and the rest of the participants is not visible for you. My name is Nadia. I'm from the Swiss Forum for Integrated Care, and this webinar is possible due to the support of our members and in cooperation with the German Association of Managed Care, the BMC. Johanna is here from this association, and the International Foundation for Integrated Care. Alejandro is representing this association today. You will see that we will share different roles in between us. As mentioned, our topic is SCIROCCO today. This instrument is not a new one. In fact, it has been elaborated quite a couple of years ago. But sometimes you need the right framework and conditions to apply a certain tool. And this is what happens in Switzerland in the canton of Vaud. And this is why we organized this webinar. We wanted to see what they did today, and we invited different people to talk about SCIROCCO initially, what it was in the beginning, how it was adapted, and how it was used in different contexts. Therefore, Alejandro from IFIC will first present SCIROCCO in its initial form and the adaptations that has been made then. Sorry for that. Oliver from Optimedis will talk about what he did for SCIROCCO. He has been working quite a time with this instrument, and how he adapted it to a specific region of Germany. Karin and Francesca from the School of Management of the Canton of Vaud will then talk about the adaptations they did for the canton and the region. In the end, Alejandro will close the presentations with a specific adaptation of SCIROCCO to telemedicine. You are free to ask your questions. Please use the Q&A. You can find it in the bottom, usually, of your screen. Here it's in German, the F&A, but you should see it in English as a Q&A. The webinar is held in English, but we have a French presentation that will be translated in English. So just make sure to select the globe and to select English as a language. Here there are wrong languages, but there should be an English in there. Well, I think this is it in the beginning. If you have any questions, even regarding the language, write it please in the Q&A and we will try to answer it. This is it. Alejandro, I hand over to you and I let you start.
Perfect. Thank you very much. My name is Alejandro Gil Salmerón. As Nadia has said, I work at the International Foundation for Integrated Care. The foundation is an international organization that promotes the adoption, the learnings, the policy, the education on integrated care in the different levels. From my experience as a researcher, I worked in one of the organizations who developed the SCIROCCO tool at the beginning, as I will say later in one of the projects, in collaboration with other partners. But I was not really linked to those projects, but I knew the person and they were in front of me in my desk. So I followed the projects really close by. And as Nadia has also mentioned, I've been using them in my professional career, adapting them for different purposes. So now for all of you who don't really know the tool and who don't really know exactly what SCIROCCO means, I have prepared this first presentation for you to give you the first view. So, one moment. Here we are. So the development of the SCIROCCO tool has been prolonged during two European-funded projects. The first of one was SCIROCCO, Scaling Integrated Care in Context, and the second one, SCIROCCO Exchange, Support Health and Social Care Authorities in the adoption and scaling up of integrated care. I highly recommend you to visit the website of SCIROCCO Exchange, because the idea was also in the project create a knowledge management hub. There is a lot of material in the on the website that you can visit on how to conduct assessment, or even how to work to perform workshops in the context of the evaluation. So this second project developed all the materials to support you in the process that we will go a little bit further in the presentation. But you had like videos, guidelines, materials for you to be supported. The context is recognizing that there is a lot of progress in integrated care, that there are many regions, many authorities doing good for this, and we want to spread, to scale up these practices all across Europe. But also understanding that the work has to be adapted or tailored to the maturity assessment, or to the maturity level of each of the regions and localities. So the SCIROCCO maturity tool came from the work developed by the B3 Action Group on Integrated Care of the European Innovation Partnership on Active and Healthy Aging. They, through the first European funding project, developed this conceptual model more to be adapted to the aim of the project. And this first project was aimed to develop this model and validate it and test it in the different regions. So the project is, or the tool is well known, because the evaluation that you can perform, but it was also thought to be thinking in one practice in order to be transferred in the new system. So now that we know that in the project they were thinking in a previous work in the B3 Action Group, we know that it was a conceptualization of what dimensions should be addressed in the transfer of integrated care. And now we can see how this was conceptualized into 12 domains. We had readiness to change, structure and governance, digital infrastructure, funding, process coordination, removal of innovators that was later on removed from the actual model, population approach, citizen empowerment, evaluation methods, breadth of ambition, innovation management, and capacity building. So this was the actual, the first model of the SCIROCCO project. And as I mentioned, removal of innovators then was not included in the final assessment tool. And in the same platform where you can conduct the assessment, because in the website you can access directly to the tool. If we choose one of the dimensions, what we can see is a little explanation for all the levels. It's easy to understand. It's translated in, I think now it's in 9 or 10 languages, and you have a rank to assess this model, as you can see here, from 0 to 5. In the process of the assessment, first of all, we need to identify the local stakeholders. Then once they are invited and accepting, participating in the assessment, they go through an individual assessment. We can identify, for example, GPs, social workers, nurses, but also we can include in the assessment ICT professionals who work in the ICT system of the healthcare system, but we can also identify policymakers and managers to collect the information from different perspectives. Once we have analyzed the results of the individual assessments, what we do is to present the different results in a workshop where all the stakeholders are able to see how the different perspectives of the healthcare system, health and care system, appears in front of the eyes of the others. So and I think this is in one of the strengths of the model, is allowing the conversation different among the different stakeholders to better decide what the maturity level is and what they need in this summary of the progress.
Alejandro,
Yes.
you have the Zoom bar on the bottom of your screen, so sometimes it's on your slide. So if you can
Sorry.
just move it away, thanks.
Yeah. So yeah, sorry. The stakeholder workshop, that, and then the summary of the results and feedback on the process and how everything has gone. So once we have the individual assessment of each one of the groups, what we have is the results organized along the 12 domains of the SCIROCCO maturity model. And one we have, this is illustrated in this spider diagram. This is what it's shared in the workshop. So you can see one of these spider diagrams per groups, frontline professionals, ICT representatives, managers, policymakers. And this is what, when they see it, they have the opportunity to share and compare these perspectives in each one of the dimensions to go for the consensus building. Once you have the consensus building, you have a final diagram when everything is in common. And then finally, what we have to understand is that the SCIROCCO helps us to understand the strengths and the weaknesses of the regional context for integrated care, where the areas of improvement are. This helps to adopt and transfer integrated care, and the maturity requirements and requirements for the potential transferability and scaling up, because we can think about what we need to better adopt practices. For example, if we know that our ICT system is not strong enough, but we want to, or we were thinking about implementing a complete ICT system for better data sharing, for example, with patients, we need to rethink how this is going to be implemented, or it will give us a vision on how the effectiveness of this intervention is gonna be, and we can start working on our ICT maturity to improve systems or put in place the systems that are going to allow us to increase the effectiveness of the model. This provides a whole complete context vision on the effectiveness of the interventions. And as I said, this or one of the strengths is not like, it's not the usual quantitative questionnaire or instrument to assess the system, but also facilitates that qualitative work with the multi-stakeholder dialogues. And based on this another example, that the work that can be done based on the results, and also comparing different countries or regions, this can facilitate twinning and coaching activities, because some I mean, when where the practice that we are thinking about has been implemented, they have good results, That could mean that the maturity is enough and they can support and aid other regions that are looking for implementing that kind of practice. And even better, the support they can be tailored to their most needed areas in the new region. So this provides also a good tool for cooperation between member states and other countries. So it's a perfect scenario, for example, or a perfect tool in European projects funded by, for example, Horizon Europe now, where the healthcare, where different healthcare systems need first to be assessed for the implementation of new interventions, for capacity and capability building, and also to support those in case of need. So thank you very much. I hope this has provided uh, a perspective on where we are and what the tool wants to provide and the different dimensions. And thank you very much.
Thank you, Alejandro, for giving us the foundations of the tool SCIROCCO. As Nadia mentioned, you can ask questions via the Q&A related to the presentation, and we'll have a discussion with all the participants later on in the end. While you think of your questions, I will quickly introduce myself. My name is Johanna, and I am the Managing Director of the German Managed Care Association. And we have some construction going on in the background. I hope the noise is bearable. I will shortly switch to my headphones. Yes, are there any questions with regards to the presentation of Alejandro? Otherwise, I actually have one or two questions. Alejandro, at what stage in a project is the SCIROCCO tool, or should it be deployed? Should it be in the beginning or at the end?
And I mean, depending on the aim of the evaluation, I mean, I could, following the logics of the purpose of the project, I would suggest to the assessment at the beginning, because then you can see the capacity of the health and care systems where you want to introduce an innovation. Mm-hmm. And then you can see first of before implementing anything, what you should be strengthening before, so the odds of failure are a little bit lower. Mm-hmm. So this provides an overview on where the capacities are, but also what should be needing improvement.
Mm-hmm. Great. And before we move on, I would really like if you could give a few examples to the dimensions, what kind of factors you're looking at. Maybe we'll get to that later also when we see how the model is actually deployed, but maybe you can give a few examples of what you're actually looking at in the dimensions.
Yes, I mean, for example, if the digital infrastructure, if it's how mature it is in the system, we need to think, for example, if there are health records put in place or not. For example, if there is how the level of patient empowerment, if they participate, if they don't participate, if there is enough, for example, evaluation of the results, so we can have access to the results or not. We know that lessons learned are really important to support the follow-up of the interventions, and they give us direction. So all these 12 dimensions support us in the multidimensional assessment of the healthcare system and help us to better implement integrated care.
Mm-hmm. Okay, thank you. And there is actually a question that popped up. Where in Europe is the model already being used? Do you know?
Yeah, I mean, I know, for example, in the project SCIROCCO, and you can, as I mentioned, follow, I mean, go and see the examples at the website of SCIROCCO Exchange. They had in the Knowledge Management Hub evaluations from Spain that I know. I mean, and they really did the work during the project. In SCIROCCO, I think they did also Puglia. In Italy, they have Lithuania, Slovakia, Poland. So they have a really high representation. But I also know that outside the project, there have been a lot of evaluations going on. Some of them have been adapting the model to the purposes of the evaluation. As I will explain later, we did it in another project, changing and tailoring a little bit the questions and the explanations for the respondents. But I know that the model has been adapted to different countries and regions like France, Portugal, Germany, a lot.
I talked to one of our board members about SCIROCCO, and she said it's actually widely being used in Scotland. So maybe that's also a place to look at.
The coordinators of the SCIROCCO project, they were from Scotland. So.
Okay, that's the reason why. Okay, so they founded it. Okay, if there are no other questions, then I will move on and hand over to our next speaker, which is Oliver Gröne. Oliver Gröne is Vice Chairman of the board at Optimedes, and he's also a professor at the Faculty of Management, Economics and Society at the University of Witten-Herdecke. Yeah, Oliver, we're really excited to hear how you deployed SCIROCCO or how you adapted it to a German region.
Thank you. Thanks for the introduction. Happy to take over and give you an insight into some of the work we've been doing with the SCIROCCO tool. And I have to explain that there are two different perspectives that we had in this project. As you know, European Union funded projects are typically structured around work packages. And together with my colleague Sophie Wang, who's now working at the OECD, we led the work package on improvement planning in SCIROCCO Exchange. That means that we had an overarching responsibility for the project to work together with all the regions that were involved, from Puglia to Scotland to Lithuania, Slovakia, to understand how SCIROCCO could be used to initiate certain projects to improve and to advance continuous learning. At the same time, we also work together with a partner organization, which is a subsidiary of Optimedes, Gesunder Werra-Meißner-Kreis, which is an integrated care network in the western part of Germany, serving a population of 25,000 people. And together with the colleagues in our local organization, we also applied the SCIROCCO tool locally. So we have two different perspectives. We worked with international partners, and we also have a in-depth understanding of actually applying the tool to a local setting. I'm going to present on the first part, but also advance on the second. So just as an introduction, where we started, we have here on the left-hand side the different regions that participated in SCIROCCO Exchange, Basque Country, Flanders, Lithuania, and so forth. And at the bottom, you can see Werra-Meißner, which is the integrated care network in Germany. In the second column, you see a value, which is the mean average of the maturity assessment across the different dimensions of the SCIROCCO tool. We use that maturity assessment here portrayed just as a mean value, but we looked at all the dimensions of the SCIROCCO model across the different regions to identify how regions rated their own strengths and weaknesses. And I will focus particularly on the bottom line, which is our integrated care network in Germany, which overall, you may say, performed with particular room for improvement, but that was also due because it was a fairly new network. So a lot of the processes, a lot of the dimensions of integrated care, as we can expect, take time to develop, to evolve, to mature. And in this integrated care network, a lot of the dimensions were not mature yet, or better said, at an early stage of development. You can see in the second or third column, the assessment was conducted just 2 years after setting up the integrated care network. We looked at the maturity assessment across the different dimensions and tried to identify strengths and weaknesses. And these strengths and weaknesses were also important for the overall project, because strengths should then be used for knowledge transfer so that regions that have strengths can transfer their experience to other regions that have weaknesses in the same regard. So there's a bit of matching or speed dating on SCIROCCO dimensions, if you wish, to exchange information on those areas. But the area where the integrated care region in Germany was performing particularly low was in terms of the digital infrastructure. And that then was also derived as a goal of the maturity assessment to improve on this digital infrastructure. And just to give you a little bit of insight on the process, the SCIROCCO assessment, the maturity assessment, was conducted by a multidisciplinary group using documentation, expert knowledge, in a workshop that ran for a number of hours to go through each of the different dimensions of the tool, look at each of the rating scales, and then find consensus on the current positioning of SCIROCCO, of the SCIROCCO tool in Germany. And as a first conclusion, already to share now, I can say that the process of actually using the tool to guide the discussion was very valuable. Because often from experience, we talk about integrated care in different contexts without perhaps clearly defining what we mean by certain terms or dimensions or objectives, and perhaps without clearly understanding a hierarchy of development, a maturity score going from one setting to another. And the SCIROCCO tool really helped highlight the discussions on those areas where particular need or development need was needed. So the improvement area that was particularly prevalent in this context was digital infrastructure. And I want to use that example to talk through the second discussion process that we had in the project, namely the quality improvement. How do we get from the maturity assessment to an improvement process? The way we conducted this process was that we compiled a lot of the information from the maturity assessment across the different regions. We looked at the knowledge transfer documents that were prepared in each of the regions, and based on that, made a draft plan for quality improvement, and then held meetings with each of the regions twice to present a high-level logic model that we constructed based on the documentation. And I'm going to explain the logic model in a moment, to show the region, this is where we believe you are based on maturity assessment and where you want to go based on knowledge transfer. And this is a model that helps you to go from A to B, the logic model. We then went into a workshop with the different regions. And after the workshops, refined our logic model and presented a second logic model to the regions, had another discussion on email, and based on that, agreed on an improvement plan going forward. For those unfamiliar with a logic model is, in essence, really a simple causal framework to understand how to get from an input to an output. And the input can be financial resources that you have, organizational structures that are in existence, relationship, collaboration agreements. These are all inputs of a system. Inputs then are the basis for activities that you can plan, things you do, things you plan, things people put in practice. So it could be events, trainings, training in particular. And these then lead to intended results, which are our outputs. And outputs are directly observable products. For example, if we talk about training, the output of a training would be the number of people trained. And the number of people trained leads then to an outcome, namely that the people that are trained have a certain knowledge or skills, and these outcomes lead to the impact. And it's quite important to distinguish the intended results at this level from output, outcomes to impact, because oftentimes we get confused in discussions about what we really want to achieve, and what we really want to achieve usually should be described here in terms of impact at the population level or the patient level, and not some tool developed or some IT deployed. So this is what a logic model is. And the best example I have of a logic model is this about baking a cake. It's from colleagues in the UK. And the essence of this model is really that often when we think about processes, we get stuck on the outputs. So the output of baking the cake might be the cake, but actually what we want to achieve is a happy party with children around the table, or also adults, eating and enjoying the cake. So there's a difference that we need to draw between outputs and outcomes. I'm going to explain why that is important. So in the German integrated care network, we worked with colleagues to identify the inputs, which in terms of the digitalization or the digital infrastructure were the organizational leadership that we had at that time to drive the digital connectiveness of integrated care providers in the region. We also had staff support because we had just set up an integrated care network and we had funding from the insurance company. We had staff in place to actually work and implement the digital infrastructure that we intended to put in place. And we had a local partnership with healthcare organizations, with hospitals, to improve on the digital infrastructure. So we had a lot of inputs available that were quite critical to work on that SCIROCCO dimension digitalization that was performing very poorly at that time in that integrated care region. Based on that, we consented a couple of activities. We agreed to train providers in the use of the electronic medical record. We also trained health navigators, health coaches, but also citizens in the use of the digital platform. We engaged with a range of partners, some of them quite clearly partners of relevance, such as a local hospital, to engage in the digitalization strategy. And then we also implemented bilateral peer-to-peer learning to put in place our digitally enabled tool. The output of these activities were the number of providers trained, the percentage of providers integrating the electronic medical record into their workflow, the number of navigators, health coaches, and citizens trained, the degree of utilization of the tool, the meaningful or number of meaningful relationships built, and peer-to-peer exchanges were outputs. The outcomes that we pursued were increased comfort and skills in utilizing a digital platform, data harmonization, and information flow between providers and patients, and the SME that was involved. And the impact was already shown here. The impact was patient-centered care embedded in the organizational culture and having a resilient and learning healthcare system that is responsive to population health needs. So this is a logic tool as we developed it based on the SCIROCCO dimension, and we developed a logic model for each of the different regions. And you can imagine the amount of discussions going into that back and forth with 9 different countries, or better said, 9 different regions, multidisciplinary teams, to agree on actually what are our key outputs, outcomes, and impact. Because this list is not a never-ending list. It needs to be prioritized. You need to agree on key outputs and key outcomes and so forth. So it was a very complex process to agree it, and I think people learned a lot in the process as well about their own objectives in the integrated care world. On that note, I think it's also quite important to state that the SCIROCCO tool can really help elicit the different stakeholders involved in integrated care to position where they are and what they want to achieve, because we have multiple stakeholders that might have multiple different objectives. The objective of a health insurance company might be slightly different than the one of a physician representative of a hospital, all working together towards the overarching goal, but still coming from a different standpoint. It's important to have a template to reach consensus, and SCIROCCO really facilitated that. So what can we therefore learn from the process? We used SCIROCCO to establish a shared understanding of where the integrated care regions are, where they're heading, what the weaknesses are, and what the objectives are. It helps to improve on the stakeholder engagement. We use the logic models to articulate and test the logical assumptions between the different outputs and outcomes, because there are assumptions oftentimes that we say we want to reach that, and in order to reach that we will do this, but the causal chain between A and B could be discussed. So this discussion really was sharpened by using the tool, and SCIROCCO with the maturity assessment really provided us a baseline, a starting point, because we didn't start discussing all at once, but we focused on one domain based on a maturity assessment which performed poorly and was consented to be the focus of discussion. So overall, a process not without challenges, but certainly supported by SCIROCCO, and yeah, full stop. Thank you.
Thank you, Oliver. So if I understood that correctly, you used the logic model to go more into depth into the details of the SCIROCCO domains.
That's right.
Okay. I have a question in the Q&A section, and then I invite also the other participants to pose their questions here. Is it possible to transfer the strengths of one country or region to others without further ado? Maybe you can say something about the process when you looked with many countries on the dimensions.
Yeah, that was one of the key discussions we've had in the project, because we identified certain strengths in some regions, say in Scotland, which has a more mature integrated care context. And then the question is, how adaptable is that learning experience or that strength to another system? And the short answer is it's probably not applicable without adaptation. You can't just take one learning from one country and apply it to another. It has a completely different health system than, say, Germany, different set of funding, different actors with different roles. But if you use those strengths and you know how they have been generated, I mean, it's not so informative to know that a system or a context has a certain strength, but it's informative to understand how they got there. And that pathway then can be, I would say, applied to another country or setting rather than the strength itself. The understanding of how you improve, how you get from point A to B, that is very valuable. And SCIROCCO had a number of lessons on these improvement processes.
Was there an improvement made after the process in Gesunder Werra-Meißner Kreis? Did you start some actions?
We did start actions. We also had a number of activities that were taking place at the same time. So it's, scientifically speaking, difficult to disentangle the effect of one from another. And there was a lot of progress made in using and developing a platform to inform patients and caregivers. I think the major challenge that we have realized in the German context was that at that time in the planning, there was an anticipation that the electronic patient record would be in place in short time. So a lot of the activities were built in anticipation that in a year from now, we will have this global infrastructure, global in the sense national infrastructure in place to exchange information more easily, and all partners can then leverage that infrastructure. And unfortunately, that didn't come. It was just introduced in Germany, as you know, a couple of weeks ago at a pilot base. So it's still not in national rollout. And that's one of the challenges when you talk about digitalization. It's so dependent on some critical infrastructures and resources. And if they're not in place, or if their deployment is delayed, then of course it has a lot of knock-on effects. But to answer your question, yes, improvements have been made, but they could have been much faster, going much further if the national infrastructure had been rolled out according to plan.
And how often did you use the SCIROCCO tool in Gesunder Werra-Meißner Kreis? Did you do it at the beginning, and then after you implemented some interventions, did you do it again?
No, there was no pre-post assessment of the SCIROCCO maturity. I think that was done in the predecessor project, but in this project we had only the in-depth, let's say, baseline assessment, and of course we had our own discussions about it in meetings that followed a year later. We discussed, we reflected, where do we stand now, but it wasn't formalized in the sense of conducting another formal maturity assessment.
Okay, I have two questions in the Q&A, and I will leave one for Alejandro later, which is about the equity considerations in the tool. And Oliver, I would like to give you the second questions. How do you measure outcome and impact on a practical level?
Yeah, that's another webinar to go into detail. At the practical level, I think you should use a logic model to separate the impact from the outcome. That's the first place. And just by signaling that there are different dimensions or different time perspectives, I think if you get a group of experts together, you will quickly identify what is an outcome and what is an impact. Impact usually more longer term, 3 to 5 years and longer, typically measured at the population level, going beyond what healthcare services are performing, and the outcomes usually much closer to the delivery of medical services, say whatever, complications or satisfaction, things like that. So it has a much shorter time frame, the immediate outcome that you want to achieve through your intervention. But there's no scientific answer to that. It very much depends on your context, on your time perspective, on the players involved. The more important question is really how you get a team together that is involved in delivery or in intervention planning, and get an agreement among those sitting at the table what they feel is the outcome and then the impact. And then you can work with that. We had done this in the workshops with the different regions, and oftentimes we had exactly this discussion that, say, a region identified something as an outcome, and we would then ask, are you sure that's an outcome? Or is it not more along the timeline of an impact? But then they might have had a good argument why it's an outcome for them. And in the end, we left it. So it's context specific and context dependent.
Okay, thank you, Oliver. I like how you highlighted that the process of using the tool, both SCIROCCO and now the logic model, is actually valuable itself because of the discussions that involve and the understanding that all the participants get. I would like to move on now to our next presentation, and I would like to welcome Karine Mati and Francesca Busisio, and they are both from Switzerland, and they have implemented SCIROCCO, and and they can give us a great insight into how the tool is deployed. They're both professors at the School of Business and Engineering in the Canton Vaud. And yeah, we're excited to hear what your experiences with SCIROCCO are.
Merci, Johanna. Je vais présenter avec ma collègue Francesca Rosizio notre travail. Je vais commencer par partager. Je pense que ça devrait être bon maintenant. Magnifique. Maria, n'hésitez pas à m'interrompre s'il y a un problème. Merci beaucoup. Donc, Francesca et moi allons vous présenter le projet que nous avons réalisé. Il s'appelle SCIROCCO Pôle, puisque son objectif était de mesurer la maturité de l'intégration des soins au niveau d'un pôle de santé. C'est un projet qui a rassemblé 5 partenaires, dont 2 équipes de recherche, à la fois la HEI-GVD, notre école, et Unisanté. Et nous avons eu 3 partenaires de terrain qui sont des pôles de santé sur lesquels je vais revenir. Il y a une petite photo d'une partie de l'équipe projet. Le projet a été financé par InnoSuisse, qui est un fonds de recherche. Et ce financement a permis de financer 8 600 heures de travail, dont la moitié pour les académiques. Et environ, finalement, 1 300 heures pour chaque pôle de santé. Il a été réalisé en 20 mois et nous avons intégré environ 150 personnes, dont 65 évaluateurs. Je vais vous présenter rapidement la façon dont nous avons adapté SCIROCCO et quelle est l'adaptation que nous avons faite de la démarche pour le mettre en œuvre. Ainsi que les résultats que nous avons obtenus. Ok, désolée. Donc, pour commencer, l'adaptation de l'outil. Pardon. Donc, nous avons commencé par vous présenter les 3 pôles de santé, qui sont 3 pôles qui ont été créés entre 2015 et 2018. Vous les voyez sur la carte, ils sont représentés par une petite étoile et ils se situent dans le canton de Vaud. Vous voyez aussi un exemple dans l'image d'un pôle de santé. Ce qui est important de prendre en compte, c'est qu'un pôle de santé est un prestataire de soins qui regroupe plusieurs activités sous la même entité juridique. Il y a notamment des soins de premier recours et de second recours, comme un hôpital des soins à domicile, des établissements pour les personnes âgées, des consultations de généralistes ou de diététiciens, pédiatres, ou de la physiothérapie. Ces pôles collaborent également avec d'autres prestataires de soins si le patient en a besoin et ils sont financés par activités comme tout autre prestataire de soins, c'est-à-dire par DRG ou par consultation. Leur objectif est d'avoir une meilleure coordination des soins qui sont assurés. Et je terminerai cette présentation des pôles sur le fait que ce ne sont pas des réseaux de santé. Alors, je rappellerai, mais Alexandro l'a très bien dit, que SCIROCCO est un outil de management et d'évaluation et que son objectif, c'est de réaliser un diagnostic pour finalement mieux gérer et mieux piloter la performance en matière de soins intégrés. Cependant, ce qui est difficile à comprendre pour beaucoup de gens, c'est que l'outil SCIROCCO a été élaboré pour un niveau macro-systémique. Et ce qui n'est pas du tout l'objectif d'un pôle de santé, puisque un pôle de santé doit mettre en œuvre concrètement l'intégration des soins. Et donc, nous avons adapté l'outil SCIROCCO au périmètre de compétences d'un pôle de santé. Et c'est pour ça que nous l'avons appelé SCIROCCO Pôle. Nous avons aussi fait une autre adaptation de SCIROCCO pour le canton et qui s'appelle donc SCIROCCO Canton. C'est pour un exemple que je vais vous donner ce petit encadré pour bien comprendre la différence entre SCIROCCO et les deux adaptations que nous avons faites. Nous avons, par exemple, pris la dimension 3 qui porte sur le financement. Et quand nous lisons la description de SCIROCCO, considérant la dimension financement, on peut en effet voir que l'outil SCIROCCO est adapté à ce que réalise la Confédération suisse, et en particulier que sur le financement, la Suisse décide des mécanismes de financement. En revanche, le canton ne décide pas de ces mécanismes, il doit les appliquer. Mais par contre, il doit ou il peut allouer des budgets spécifiques pour des activités ou des prestataires de soins sur son territoire. Et pour terminer, un pôle de santé, évidemment, ne décide pas de ses modalités de financement, mais il décide, lui, de répartir ses financements en fonction des activités qu'il souhaite réaliser. Il peut mettre en place des outils de gestion financière ou chercher des financements externes. Je vous ai
Karine,
représenté ici
Karine.
les trois types de compétences distinctes entre la Suisse, le canton et un pôle de santé. Et comme vous pouvez le voir, nous retrouvons qu'au niveau de la Suisse, le pays doit décider des mécanismes de financement. En revanche, au niveau du canton, le canton a pour compétence de savoir comment il veut répartir les financements et l'organisation des soins. Et pour finir, le pôle de santé doit lui décider de sa production de soins et de son organisation. Donc, nous
Karine,
avons
est-ce
en
que j'ose
fait
juste vite,
travaillé sur ce sujet, puis sur le SCIROCCO canton. Alors, sur le projet SCIROCCO, nous avons donc gardé les 12 dimensions des soins intégrés identifiés dans l'outil SCIROCCO. Ensuite, nous avons adapté et opérationnalisé chacune des 12 dimensions au contexte des pôles de santé. Et ensuite, nous avons standardisé et amélioré l'échelle de mesure d'origine pour qu'elle s'adapte à toutes circonstances. Je vais passer la parole à Francesca qui va vous présenter l'implémentation de SCIROCCO-Pôle.
Très bien, merci Karine. Et puis, j'ai désactivé la modalité en anglais. Ouais, vas-y Nadia. Nadia, tu voulais dire quelque chose?
I just wanted to signal that we in the English channel hear French and English both together. So I think when Karin and Francesca are talking, they need to be on the French channel. And then to hear what the people are saying, they have to switch back on the English channel so that it's easier for us to follow.
Parfait. Alors, je vais continuer avec la manière dans laquelle nous avons concrètement adapté l'outil SCIROCCO pour l'évaluation à la fois des pôles et du canton. Donc, l'idée pour nous était vraiment de mettre l'accent, comme Oliver l'a déjà expliqué, sur la discussion qui vise à fixer le score dans chacune des dimensions, puisque c'est ces discussions-là qui vont aider ensuite dans les plans d'action qui suivent l'évaluation SCIROCCO. Donc, l'idée, c'était d'avoir différentes perspectives. Donc, nous avons impliqué 12 à 24 personnes par pôle. Donc, nous avons fait à la fois une évaluation interne, enfin, une évaluation par des professionnels internes à la structure et des personnes qui étaient externes à cette structure avec différents niveaux de responsabilité, c'est-à-dire stratégique et opérationnel. Pourquoi? Parce qu'on voulait mettre en dialogue, vous verrez dans la suite de la présentation, ces deux niveaux. Ensuite, nous avons aussi impliqué des patients et puis des proches aidants, on les appelle en français, donc des informal caregivers. Et l'idée était là aussi d'avoir la perspective, en particulier sur certaines dimensions de l'outil, de personnes qui n'étaient pas des professionnels. Comme j'ai dit, cette discussion, donc cette idée je vous la montrerai, d'avoir d'abord une évaluation individuelle, puis une évaluation par groupe de compétences, et puis ensuite une évaluation mixte, était vraiment de soutenir et guider les pôles vers la réflexion sur les évolutions stratégiques et opérationnelles futures. Donc, on a vraiment pris beaucoup de temps pour documenter les résultats pour que ce matériel soit mis à disposition des pôles. Donc, les chercheurs, dans ce contexte, n'ont pas participé à l'évaluation et à la décision, à la prise de décision sur les plans d'action ou la stratégie. Ils fonctionnaient comme des catalyseurs, c'est-à-dire qu'ils ont réfléchi à des méthodologies pour permettre l'atteinte d'un consensus au sein de ces différents groupes. Nous avons un schéma pour vous montrer concrètement les étapes que nous avons suivies. Karine, tu peux changer. Voilà, donc dans la première phase, comme l'outil l'indique, nous avons procédé à des évaluations individuelles, c'est-à-dire que le questionnaire SCIROCCO, enfin l'outil SCIROCCO a été transformé en questionnaire, que les 24 évaluateurs ont reçu pour pouvoir effectuer une évaluation de chacune des dimensions sur une échelle de 0 à 5. Et ces experts étaient, comme je l'ai dit, à la fois internes et externes au périmètre du pôle. Ensuite, nous avons, sur la base après cette évaluation individuelle, fait 2 types de rencontres de consensus. Donc ça, c'était vraiment l'approche participative ou de coproduction que nous avons souhaité créer pour aider les pôles dans leur développement futur et à comprendre mieux pourquoi le diagnostic de chaque dimension avait été posé de cette manière. D'abord, on a fait un consensus par type de personnes, donc en fonction de leur niveau de responsabilité. Donc, d'une part, il y avait les personnes avec une responsabilité stratégique. Et ensuite, on avait un groupe de personnes qui avaient une responsabilité opérationnelle. Dans la deuxième phase, donc les consensus de type 2, on a mis ensemble des représentants de chacun de ces groupes. Donc, ces représentants de chaque groupe agissaient comme porte-parole du diagnostic sur lequel le groupe s'était mis, chacun des 2 groupes s'était mis d'accord dans la phase précédente. Oui, merci. Donc, les résultats de l'évaluation, comme ça a déjà été montré, ont donné lieu à un graphique en radar, un diagramme en radar qui mesurait pour chacune des dimensions le niveau de maturité évalué de manière consensuelle par le dernier groupe, donc celui qui mixait les personnes avec une responsabilité stratégique et les personnes qui avaient une responsabilité opérationnelle. Ce graphique était assorti d'une documentation qui expliquait pourquoi on avait choisi un score plutôt qu'un autre. Ensuite, dans la deuxième phase, on a invité les pôles, on a donné des outils aux pôles pour, sur la base du diagramme, pouvoir répertorier le score actuel et ensuite le score visé en fonction aussi des développements futurs qui venaient pas seulement des pôles, mais aussi du canton. Et c'est la raison pour laquelle, en parallèle à l'évaluation du pôle, on a aussi effectué une évaluation du canton parce que, comme vous l'a expliqué Karine, les pôles n'ont pas la main sur, par exemple, le financement ou, par exemple, les activités ou le périmètre de leur activité ou les collaborations avec certains prestataires externes au pôle. Donc, cette phase de roadmap permettait aussi au pôle d'intégrer des informations, des contraintes qui lui venaient de l'extérieur. Ensuite, les pôles étaient invités à choisir 3 axes stratégiques, enfin 3 dimensions à évaluer, de fixer le score qu'elles souhaitaient atteindre d'ici à 3 ans, et ensuite de développer pour chacune des plans d'action qui expliquait quoi, comment, qui et combien, donc en termes de budget, mais aussi d'indicateurs. Donc, de fixer des indicateurs pour mesurer, au-delà du score de maturité en matière d'intégration des soins, en quoi le succès du projet allait être mesuré, et puis de créer une matrice de faisabilité, d'impact et de risque, c'est la petite image que vous voyez en bas à droite, pour essayer d'anticiper sur les difficultés qui pourraient être rencontrées dans la mise en œuvre. Donc, puisque ce travail, nous l'avons fait en canton Vaud, mais pourrait être utile pour la Suisse, et notamment en matière d'évaluation des cantons, de la maturité, du niveau de maturité de l'intégration des soins dans le canton, nous avons créé un guide d'utilisation, SCIROCCO/canton, qui décrit vraiment dans beaucoup de détails comment nous avons appliqué cette démarche et puis aussi combien de personnes en termes d'heures investies. Donc, Karine vous a dit au début, il y a eu plus de 8600 heures investies, dont 1300 pour chaque pôle. Donc, ça montre aussi l'importance de l'investissement des partenaires de terrain dans cette démarche. Donc, et qui a en annexe les questionnaires SCIROCCO-Pôle et SCIROCCO-Canton que nous avons spécifiquement adaptés pour ces 2 contextes. Donc, si jamais le guide vous intéresse, on a un QR code que vous pourrez flasher à l'occasion et qui vous donne accès justement à ce matériel. Évidemment, on est à disposition si les personnes souhaitent un échange d'expérience. Donc, qu'est-ce que les pôles nous ont dit après cette expérience? Alors, si on devait refaire cette démarche, alors oui, mais très clairement, il faudra mieux communiquer et expliquer les objectifs du projet pour être sûr que les personnes impliquées adhèrent à la démarche du début à la fin. Donc, il faudra identifier mieux et plus rapidement les personnes qui, à l'intérieur du pôle aussi, doivent conduire ce projet, puisqu'on a vu que, surtout au niveau des groupes de consensus stratégiques et opérationnels, on perd des personnes en cours de route. Et puis, il faut mieux définir aussi qui sont les évaluateurs externes. Et puis aussi, quel type d'agenda ils incarnent. Ensuite, il faut dédier plus de temps. Donc, ils constatent, comme nous, qu'il faut dédier plus de temps pour l'après. Donc, poser un plan stratégique et puis développer des plans d'action et des projets. Et puis, parce que c'est pas une activité qu'ils font souvent et avec ce type d'outils. Si on devait recommencer dans 3 ans pour faire une évaluation post, la réponse serait oui, mais donc ce serait oui pour pouvoir mesurer à la fois le progrès qui a été fait dans les 12 dimensions et puis évaluer sur les 3 dimensions pour lesquelles il y a eu un score cible a vraiment été atteint. Et puis pour évaluer aussi la pertinence des outils et de la feuille de route stratégique et les actions, les plans d'action qui ont été posés en théorie lorsque l'évaluation a été faite. Ensuite, pour les chercheurs, l'idée, c'est de réfléchir mieux à comment intégrer les patients et les family caregivers, donc les proches aidants, puisqu'on a vu qu'ils étaient un peu timides et le setting dans lequel on les a amenés à s'expliquer ne permettait pas de réunir les conditions vraiment de leur autonomie et de leur liberté d'expression. Ensuite, on réfléchit à une 13e dimension qui est la coopération entre les pôles santé et les partenaires externes. Donc cela peut être aussi, parce que les pôles, comme vous l'avez entendu, ont une situation particulière dans le canton et en Suisse, mais cette 13e dimension pourrait être utile aussi en Suisse pour les cantons, qui parfois se réfèrent à des partenaires externes, par exemple pour des disciplines de la médecine hautement spécialisée. Bien, voilà. Merci de votre attention et nous prenons volontiers les questions.
Thank you, Karine, and thank you, Francesca, for sharing your experience and also for being so transparent about what you would do differently and also sharing the experience with other cantons in Switzerland. What stuck out to me was the 2 to 3 hour interview that was done, and you did it with 24 people. So for a very small number of people, it's a lot of workload. Did you have difficulties finding the participants for the interviews?
Are you speaking about the questionnaires of the individual evaluation? Okay.
Yes.
So, in fact, the evaluators were chosen by the health pool. So they were in charge of choosing the evaluator, and then the questionnaire was individual. We were not supporting people in their assessment. What we did, we created a questionnaire and then we put that on a platform so that people could do that online and then come with a printout at the consensus group in order to discuss mindfully based on what they wrote or noted and reach consensus in each of the groups, the operational and the strategic.
And you said you included patients and caregivers, even though it should be done differently the next time, but how did you do it the first time?
So the first time we asked the poll once again to designate some people that were already involved in projects that were steered by the polls. So as you know, we try to co-product, so in Switzerland and elsewhere, we try to involve much better patients and their caregivers in co-producing services that are more adapted to their needs. So these people were already involved in projects of the polls. and they participated on a consent, so if they agreed to do that. So what happened is that they received the questionnaires as the evaluator, and then they participated into the groups, the consensus groups. And it is there that we saw that it was very difficult for them to endorse the legitimacy to speak out in front of professionals. So maybe we are reflecting that maybe interviews will be better for them. And then we are like spokesperson of, or someone in the pole or the canton is spokesperson for the patients and the caregivers in order to so maybe improve their capacity to speak out without fearing a negative feedback.
Someone is asking what was the major insight in terms of provision of care, also between the three poles.
Karina, do you let me go ahead? Okay. So the three poles, even if they are very small regions, they have a lot of special funds. They are different. So we don't have something really convergent. But as the colleagues said already, so the problem of the digital infrastructure, the funding was very much discussed. So things on which they don't master, they don't decide. So are somewhat pointed as being the problem to provide care as they would like, provide integrated care. About the funding, we have to say that it's not easy in Switzerland to do integrated care since, as Karin explained, the payment is per activity. So we don't, so it's really fragmented. And so it's difficult to make all these actors communicate because we don't have funding for them to communicate, right? So communication is so when it happens, is more on writing, and we don't have time to solve or make the information work better. And this is where the digital tools are critical to improve that, but they don't decide about the digital tools they can use.
Okay. Thank you, Francesca. Thank you, Karin. Alejandro, I will hand over back to you because you are sharing with us your application of SCIROCCO in telemedicine, I believe, which is also a very interesting field of deployment. But maybe I can give you the question in the chat. How are equity considerations taken into account with SCIROCCO, that you answered that prior to your presentation?
Yes, perfectly. I had to take a look because it was a long time ago since I have this kind of reflection. But actually, this is the population management dimension, the one that looks at this, because as we understood and we understand integrated care, sometimes people with greater needs are the ones that had this kind of inequalities or suffer more health inequalities or lack of access to the services. So we need to better coordination of services and sectors to really reach those groups and keep them, keeping more continuous delivery of care for these groups. For example, in the case of people experiencing homelessness or crisis management for people in mental health, there are not just one provider. We need more providers and more sectors working with them, their caregivers. So yeah, population management would be the approach that assess the health and care system and services.
Thank you. And now let's switch to telemedicine.
1 minute. Sharing. Wait. So, wait, no. So this is the work that we conducted in 2021. Yeah, by the end of 2021, in the framework of the project ROSIA, Remote Rehabilitation Services for Isolated Areas, in the work package 2. Now that we are familiar also with the concept of work packages and the work that we conduct, the first thing that we have to understand is the typology of the project. This project was not research oriented. This project is a public procurement project in which different regions opened a procurement process, and now there are companies. Currently there are companies that are testing the solutions that they have developed during the last 2 years to respond to the procurement process. In that framework of the project, we have the work package 2, the remote rehabilitation model design, where we were working, the International Foundation for Integrated Care and myself in it, in the development of a comprehensive care model that the solution should be following or addressing in collaboration with other knowledge partners in the project. So we know that there is a rising burden of chronic conditions and limited resources, but we can see also like this is more and more prevalent in rural areas where there is a high proportion of older adults, and we can also see one of the most difficult barriers as the distance for patients to reach when there were long distances to have access to healthcare are more limiting. In this case, we were also focusing on rehabilitation as a key component of care, treatment and support, seeing it as a comprehensive part of the continuous of care. But with all this picture that I'm trying to give you, and the ones that are leaving a high portion of patients in the countries and regions where with the ones that we were working on the project, most of the people must travel great distances to specialist centers to access to these services. So when we were thinking about integrated care, we were looking for increasing access to rehabilitation care. We were looking for more a more close collaboration, networking, and alignment of the professionals, caregivers, and the individuals with this type of needs. We were looking also for ICT enabling care, and trying also to reduce, or at least making more efficient or making better use of money of the telemedicine. So in this context, in work package 2, we did this little study with the resources that we had, adapting the SCIROCCO tool to assess the readiness of health and care systems in Ireland, Portugal, and Spain, more in Cork, in Coimbra and Aragon, in these 3 countries. And we started in April to June in 2021. We identified different stakeholders in 3 main levels. In the micro level, we identified patients association representatives, care team representatives, and rehabilitation representatives. At the meso level, we identified professional, healthcare administration, and ICT managers. And at the macro level, we also looked for payers, policy makers, public health and social care authorities, representatives. And we didn't use just the SCIROCCO self-assessment tool adapted for the rehabilitation. What we did was to provide also an initial letter explaining the first the SCIROCCO, and then the use that we wanted to give to the tool. We, after contextualizing this, we also contextualize what was telerehabilitation and what we meant by that. We also included the telehealth capacity and telehealth readiness assessment tools, also to have these two more specific tools, but also the SCIROCCO one, because we thought that it was a more comprehensive of all the systems and services that we wanted to work with. So we had the model that I have already explained. So the results of specifically the ones, and and in methodology, I have to say that we just collected the data quantitatively because we hadn't got the resources to go into the qualitative part. I think this, and as I will explain later, was a lag from our part, and all the interpretations were based on our experience in the healthcare systems, and not decisions that were consensuated in the workshop. So as you can see, there are different levels of adaptations of the SCIROCCO tool to the reality, and different levels even of going through all the process. In this case, the SCIROCCO tool revealed overall pool readiness for innovative telerehabilitation services across the 3 countries, but we identified some differences in the 3 countries, as I will mention now. In Ireland, evaluation methods scored the lowest, indicating a lack of assessment for integrated care services, but however, the digital infrastructure received higher ratings. Portugal showcased strengths in innovation management, but lacked evaluations, and in Spain displayed higher maturity across dimensions, especially in the population approach, although removal of innovators and barriers scored lower. So from this little and short exercise, because as you have seen in the previous presentation, this can serve for taking a picture, or even to start these in-depth conversations for better planning the adaptations and the work in its systems for resources allocation. This gave us a picture on how the different perspectives were, and also the orientations for the companies for the development of their results for now. No, when we are testing their technologies. So we can see the disparities in readiness for integrated telerehabilitation across the 3 countries, and in Ireland, they had a good digital infrastructure and lacked support from comprehensive evaluation methods, necessitating immediate focus on establishing effective assessment frameworks for service evaluations. And in Portugal, the strength in innovation management faced challenges due to the absence of evaluations, urging a critical need to validate and measure the impact of innovative practices within integrated care systems. And finally, Spain's higher maturity in specific dimensions signals promising strategies. However, barriers hindering full integration need to be addressed to maximize its impact. We can see, like in general, for example, it was the lack of evaluation in healthcare settings, but both the major barrier for the adoption of integrated care, and also not just because when we talk about the adoption, we are not just talking about pilots, but also full adoption of this kind of interventions. So now we are in a phase where the companies have developed their solutions based, among other parts of the model and documents that we have provided to them. They are now testing the solutions, And we thought that provided them a piece of the roadmap that they should be looking at when developing their solutions. So I also invite you to look at the website of Rosia to see how this is evolving, and in in few months more, or maybe in 1 year, the final results of this project and the rehabilitation telerehabilitation solution that will be out by then. So thank you very much, and I hope this other example has helped you to see other kind of adaptation of the SCIROCCO and another application, just to see how this can be used. Thank you very much.
Thank you, Alejandro. I think it was really interesting to see all the different contexts where the tool can be used for. We only have 4 more minutes, so I will just give one final question to each of the participants, which is, when would you recommend using the tool? Maybe you can still put it in a nutshell, and that would be a good end for our session. Oliver, what would you like to start with your little when would you recommend using SCIROCCO, maybe, for all the other Germans in the audience?
Yeah, I think it's at the beginning of the process where it's particularly useful, I think, because it can get stakeholders together for a guided discussion, which otherwise might not be so guided. I think it would be very valuable to look at integrated care arrangements given the current hospital reform, which gives new incentives for hospitals to engage or to devolve into the community. So for smaller hospitals, together with primary care providers and local commissioners, if you wish, this might be a very useful tool to identify where they want to go together in a partnership.
Great, thank you. Francesca and Karine, whom would you recommend and when would you recommend to use it?
Well, I would say that when this kind of structure, like an health pole, starts, and a few months or maybe 1 year or something like that, to have a baseline assessment of their own capacity to build integrated care, and then we thought that maybe 3 years interval is quite good to assess progression in dimension, and considering also the rhythm at which in Switzerland political decision is made.
Great. Okay, thank you. Nadia, I think you will provide us with the slides, right? I see her nodding. Yes. So thank you all for your time and your attention and your expertise. It was very interesting. I wish you all a nice afternoon, and I can only say keep on fighting for integrated care.